So we're going to move on to chapter 13 about the endocrine system and disorders associated with the endocrine system. We'll spend a little bit of time just talking about the endocrine system in general and some disorders associated with it. And then we will spend a longer time talking about diabetes, which is the most common endocrine disorder and the one that you will encounter the most in the clinic. So the learning objectives um, for the whole chapter, explaining the function of the major endocrine glands and their hormones, diabetes mellitus, including types 1 and 2, pathophysiology and treatment, symptoms, complications of diabetes relevant to PT practice, then several different endocrine diseases, Cushing's, Addison's, which are cortisol diseases, and hyper and hypothyroidism, which are thyroid diseases. And what's the PTA's role in managing patients with endocrine disorders and recognize when to alert the supervising PT about patient status changes? So the endocrine system, in general terms, it's the two main control systems in our body are the nervous system and the endocrine system. The nervous system generally exerts pretty quick control, and the endocrine system exerts a little bit slower control. But the endocrine system is a set of glands throughout our body or organs that produce and secrete hormones, and they secrete them directly into the bloodstream. That's the difference between an endocrine gland and an exocrine gland. The hormones circulate through the bloodstream until they encounter target cells or target receptors, more likely, and they enter their target cells through those receptors and perform their function. So, excess hormones or waste products from their metabolism travel through the circulatory system and are metabolized by the liver. So, the liver is just working away no matter what. We'll talk more about the liver later in the quarter. Um, from the liver, after they're metabolized, they travel to the kidney for processing and excretion from the body. That also happens with a lot of medications that we take. They get metabolized in the liver and they get excreted through the kidneys. So hormone levels, the key structures for the endocrine system are the hypothalamus, which is in the brain, in the midbrain, the pituitary gland, which is also sometimes known as the master gland, thyroid and parathyroid glands, adrenal glands, which perch atop the kidneys, one on each side, the pancreas, which hangs out near the stomach, and it has exocrine and endocrine functions, and the gonads, which are in the pelvic cavity, male and female, are different, obviously. We'll talk more about that. So each gland secretes hormones that regulate metabolism and body functions through the bloodstream. So the nervous system is doing its job, the endocrine system is doing its job. They're all working together. So the hypothalamus, strictly speaking, is part of the nervous system, but it controls the endocrine system. So hormone regulation are the levels in the body are controlled by negative feedback loops. So if circulating hormone levels are too high, hormone production and release diminishes. If circulating hormones are too low, then you get secretion from endocrine glands to increase the levels. So, a lot of times, two or more hormones work in antagonistic relationships. One hormone might increase the production of the substance while a different hormone decreases the production. So in diabetes, that's a really good example. The hormone insulin is produced and used by cells. Glucose blood levels drop, stimulating the pancreas to release a different hormone, glucagon, which causes the liver to release stored glucose, which raises blood glucose to normal levels. So in diabetes, insulin production and usage are impaired, so glucose levels in the blood remain high. So basically, what I always say is that insulin escorts blood sugar into the cells. So if you don't have that, it can't get into the cells, it hangs out in your blood. And so you have hyperglycemia, too much glucose in the blood. There's the emia part. So those antagonistic relationships exist in a lot of pairs. So ghrelin and leptin. Ghrelin's the hungry and leptin's the full for the stomach. And insulin and glucagon. One of them mobilizes glucose, the other one stores glucose. So they work in little pairs, which is lovely. So they by far the most common endocrine disorder is diabetes, and we're going to talk about that in the next section. But the timing of hormone production and release varies according to the function of the hormone. So in females, estrogen production increases and decreases within a monthly cycle, and then it changes during pregnancy, and then it changes again during menopause and after menopause. So a lot of hormones remain at a fairly constant level all the time. Only in clinical cases with hyper or hypofunction do we see dramatic changes in hormone levels. As we age, even if we're producing the same level of hormones, we might have reduced susceptibility or increased resistance to those hormones or fewer receptors. So the hormones are still secreted, they don't act as quickly. So both male sex hormone, testosterone, and female estrogen diminish with age. Those are the only ones that diminish with age. The rest of them, we're still producing them. So we're going to talk about diabetes in the next section, but we're going to talk now about the adrenal, the hormones that are produced by the adrenal glands, which are cortisol. So Cushing's disease, a lot of hormonal diseases besides diabetes are caused by tumors. So Cushing's disease is caused by a pituitary gland tumor, usually benign, but it oversecretes the hormone ACTH, overstimulating the adrenal gland's cortisone production. So Cushing syndrome is the signs and symptoms of excess cortisol from any cause. Cushing's disease is the pituitary tumor cause of it. So that there's a little bit of difference, but similar things. So an endogenous cause of Cushing syndrome could be pituitary, adrenal, or lung tumors. Exogenous causes can be long-term steroid medications like long-term prednisone or hydrocortisone use. And many patients are on chronic steroids for autoimmune conditions because that's one of the ways that they can treat autoimmune um, conditions, which can then cause endocrine problems. So Cushing syndrome, the medications, they act on cortisol in the body, so the signs and symptoms relate to excess cortisol levels. The physical appearance is, they call it a moon face, so round and full. Buffalo hump, which is a fat deposit on the back. Central obesity with thin arms and legs. Purple striae, which are stretch marks. And thin, easily bruised skin. That's a typical Cushing syndrome presentation. The systemic effects include hypertension and hyperglycemia, and osteoporosis, which develops into fracture risk, slow wound healing, and muscle weakness. So that's having too much cortisone. Addison's disease is the opposite problem. It's too little cortisone. So it's adrenal insufficiency. Autoimmune destruction of the adrenal gland is the most common cause of Addison's disease, and it can also result from tumors or infections. So the signs and symptoms of Addison's disease are sort of like, if you look at it, sort of like the opposite of Cushing's. So instead of the buffalo hump and the central obesity, you have weight loss and dehydration. You have hypotension, low blood pressure instead of high blood pressure. You have hypoglycemia instead of hyperglycemia. You have increased skin pigmentation, which sometimes they call bronzing, profound weakness and fatigue, and abdominal pain. So an Addisonian crisis is a medical emergency. There's a sudden drop in blood pressure. So a lot of times, people who are being treated for with steroid medications, if the steroid medications are removed suddenly, there's not enough cortisol and the patient's blood pressure could drop dramatically. So the Addisonian crisis, like you suddenly don't have any cortisol. Um, so it can be triggered by sudden stress, abrupt steroid withdrawal, or missing hormone replacement doses. Severe hypotension, and that's the life-threatening 911 part. Um, Vomiting and dehydration, which can also eventually lead to life-threatening metabolic acidosis or alkalosis, confusion and altered mental status, and it can be fatal without immediate treatment. So notify the PT if you think someone's going through this Addisonian crisis, and call 911 and monitor their vital signs until the ambulance gets there. So hyperthyroidism is basically, you can kind of think of the thyroid conditions as either you have your metabolism's too fast or it's too slow. So the most common cause of hyperthyroidism, which causes a revved up metabolism or an increased metabolism, is Graves' disease, which is autoimmune, affects the thyroid gland. So the signs and symptoms of Graves' disease, basically, the thyroid gland takes iodine from our food and converts it into thyroid hormones. So thyroxine, T3, T4, and T3, basically. Thyroid cells are the only cells in the body which can absorb iodine. None of our other cells can. So the cells combine iodine and the amino acid tyrosine to make T3 and T4. So the T3 and T4 are responsible for controlling metabolism throughout the body. So if you have too much, then so Graves' disease, the autoimmune system directly attacks the thyroid gland, and it predominantly affects women under the age of 40, although men can be affected by Graves' disease as well. So it's basically a hypermetabolic state. So you have a rapid heart rate, so cardiac tachycardia, hypertension, anxiety and irritability, tremor, weight loss, frequent bowel movements, diarrhea, bulging eyes, fatigue, thick red skin, and sexual disorders such as amenorrhea and reduced libido. An enlarged thyroid gland, which is called a goiter, may also be present. So it revs up your metabolism and causes a lot of problems, basically. A thyroid storm is another endocrine life-threatening emergency which can be triggered by stress, illness, surgery, or emotional trauma. So if somebody's in the hospital, do you think they're undergoing stress, illness, possibly surgery, and emotional trauma? Yeah, probably. So the signs are your it's a medical emergency. It's hyperthermia. So you have a fever, you're hot, and your skin is sweaty. Severe tachycardia, the hypertension, delirium, and extreme agitation. So delirium is confusion that goes away. Dementia is confusion that doesn't go away, if you want to think of it that way. Um, a thyroid storm can progress to heart failure and death because of that severe tachycardia. The mortality rate is up to 75% if untreated. Isn't that crazy? So if you think somebody's undergoing a thyroid storm, immediate medical attention, a cool environment, and monitoring closely until you hand them over to the healthcare team. So hypothyroidism is the opposite problem. It's a slowed down metabolism. So some people have hypothyroid because they had something like a tumor or something where they had to get their thyroid removed. It could be autoimmune, which is Hashimoto's thyroiditis. Just the opposite symptoms of hyperthyroidism. So you could make a little chart of all these and compare and contrast. Like when you're buying something and they say, oh, compare this to another model, you could do that with endocrine disorders. So bradycardia, slow heart rate, hypotension, weight gain instead of weight loss, lethargy and depression instead of agitation, cold intolerance instead of being hot, dry skin, hair loss, constipation instead of diarrhea. So it's just the opposite of hyperthyroidism. But the thing that's the same is you may have a goiter with either one. And that's just faulty iodine metabolism, basically. And a goiter is visible from the outside because the thyroid is kind of right on your neck, right under your neck, or nestled around your trachea. So hypothyroidism is treated with hormone replacement therapy, usually for life. The thyroid stimulating hormone and T3 and T4 can be replaced with synthetic hormones, and the patient can live a relatively symptom-free life. Isn't that lovely? So there is a severe hypothyroidism that's called a myxedema coma. It's kind of the opposite of a thyroid storm. So most of the endocrine things have an opposite, you might notice. So the characteristics of myxedema coma are non-pitting edema, so non-pitting swelling, facial puffiness, thick tongue, slurred speech, hoarse voice, hypothermia, you're cold, decreasing mental function. It can be to the point of a coma. It's rare in the US due to early recognition and treatment, and it's treated with synthetic thyroid hormone replacement. I read this really interesting case study about a woman who had myxedema crisis, basically, and the pictures were outrageous. You should take a look at them sometime, but very interesting. So, pituitary disorders, the pituitary gland is called the master gland because it secretes a lot of different hormones that affect other endocrine glands. So, the pituitary gland can be dysfunctional due to congenital conditions. Tumors, either benign or metastatic, are one of the most common causes of pituitary disorders, or it could be the reaction to some drugs. So lots of different hormones are produced by the pituitary gland, and growth hormone. If if you have hyperpituitism, you can have excessive height in children, or acromegaly in adults, where the hands and jaw continue to grow and you have enlarged features. So that's often caused by a tumor. Other hormones that are affected by pituitary disorders are thyroid stimulating hormone, ACTH, prolactin. So benign tumor is the most common cause, but sometimes caused by drugs or congenital conditions. So if you have a hyperpituitary thing, it's most likely a benign tumor that's causing it. Some of them are managed by medication. Some of them, it's really hard to take out the pituitary gland because it's right in the middle of a lot of important structures. But brain surgery. Red flags when to alert your supervising PT. If your patient has sudden confusion, dizziness, or altered mental status, yeah. Severe hyper or hypotension, signs of hypoglycemia like shakiness, sweating, and confusion, chest pain or severe shortness of breath, high fever with a rapid heart rate, new or worsening wounds, especially on the feet. Or if the patient reports that they missed their medications, document everything and communicate promptly. That might even need a call to the doctor's office. So, exercise consideration with endocrine disorders. For thyroid conditions, if someone is hyperthyroid, you want to monitor their heart rate and you want to avoid overheating. Hypothyroid, they may have exercise intolerance, so you want to start slowly. With adrenal disorders, with Cushing's, which is hyper cortisol, there's a fracture risk and skin fragility. With Addison's, fatigue is a big issue, and they may need extra steroids for stress when they're in a stressed condition. So the medications that people are taking in general, if they have cortisol issues, prednisone and hydrocortisone can actually cause Cushing symptoms, but they should never be stopped abruptly because then you're risking an Addisonian crisis. Thyroid medications include synthyroid. You hear that a lot for people that have had their thyroid removed or even partial removal. It's synthetic T4, and then Cytomel is synthetic T3. So those synthetic thyroid hormones are commonly used with hypothyroid. So you really should understand the pathophysiology of major endocrine disorders. Most of the time, they're caused by benign tumors. But also, you should recognize the signs and symptoms that require immediate attention. You want to monitor patients carefully during treatment sessions, communicate changes promptly to the supervising PT, document thoroughly and accurately, and educate your patients within the scope of your practice. So, as usual, patient safety is our top priority, and when in doubt, ask for help.